So Alain, Anne, Giuseppe, the Teaching and Training Working Group and I are pleased to introduce today to the second ITHACA webinar. This webinar initiative is new and has the goal of responding to the training needs of our ERN professionals for some, as well as those of the patient support group and patients for others. So this first webinar has a fascinating topic on the care of patients with intellectual disabilities advancing in age. It will be composed of in two parts. Part one, aging with ID, which I will moderate, and part two, ID care and recommendation that Tichke will moderate. And Giuseppe will then conclude this webinar. For this webinar, more than 90 professionals registered. Our audience goes over the scope of the ERN ITHACA and also beyond the EU. This webinar has been also relayed to other ERN also concerned by aging and with ID. I hope you will enjoy these initiatives. This webinar will, of course, be available for replay. Don't hesitate to contact us if you want to do a webinar or if you have interesting ideas to share. And let's start now with the first presentation with Stephanie Mio. The presentation is entitled Geriatric Syndrome in Older Adults with ASD and ID, Results from EFAAR Study. Thank you, Stephanie. You're mute at the moment, but
yeah, you're muted,
I think you know. Yeah.
I just want to share my presentation.
No, I can do it.
Okay, thank you very much.
You just let me know when it's time to turn.
Okay, I say next.
You're welcome.
Okay, thank you. Thank you for your invitation. So I'm Dr. Stephanie Mio. I'm geriatrician, but also psychiatrist and neurobiologist in the south of France, in Montpellier. And together we will speak about geriatric syndromes in older adults with autism and intellectual disability, with a specific focus on our results for the EFAAR study. Next. So we will speak about aging definition in general populations. Then we will have a look to data about aging with a neurodevelopmental disorder. And we will conclude with the issues and the perspectives. So what about aging definitions in general population? Aging is characterized by a decrease of physiological reserves and adaptability. And you can observe on your left. Okay. You can observe three types of aging. Normal aging in green, after a period of maturity, accelerated aging in red, with a beginning during the maturity phase, and an early aging in orange, which is more rare and begins during the development phase, as in progeria, for example. Next. This higher vulnerability is influenced by physical activity and nutritional factors, and it can lead to frailty. On your left, you can see a robust older adult in green and a frail older adult in red. And after a minor acute stress, the frail adult loses more autonomy than the robust, and it takes more time to recover this functional ability, with usually a lower final autonomy level after this acute stress than the previous functional ability level. Furthermore, we know that frailty can predict falls, hospitalization, and death. Next. Frailty can be assessed using some tools. In daily practice, in geriatrics, we use the phenotypic model. Your patient is defined to be frail when he has 3 criteria on the 5 here: weight loss, fatigue, activity decrease, wall speed decrease, and muscular weakness. Next. We can also use the cumulative model and the Frightly index. The Frightly index is the ratio of the defect sums on the total number of clinical and biological assessed parameters. Next. And this Frightly index help us to calculate the biological age in order to characterize the aging trajectory of our patient. For example, we have a patient who is aged about 80 years old. He has a Frightly index of 0.1. His biological age is around 70 years old, so we can think that he has a successful aging. On the contrary, if his Frightly index is about 0.2, his biological age is around 90 years old, suggesting a pathological or even accelerated aging. Next. There is a complex synergy between Frightly, comorbidities, and disability. Frightly induces an higher risk of pejorative comorbidities evolution, and comorbidities are a risk factor for Frightly. Next. Comorbidities. Next. Yes, thank you. Comorbidities can be sorted into chronic health conditions to assess multimorbidity. Multimorbidity is defined as the coexistence of two chronic health conditions in one individual. And this multimorbidity, as you can see on your left, increases with age. On the pathophysiological point of view, multimorbidity is influenced by functional status, and it's underlying by the inflammaging process. What is inflammaging? This is a chronic low-grade inflammation which accelerates aging. Next. Multimorbidity is frequently associated with polypharmacy. Polypharmacy is characterized by taking 5 or more different drugs per day. And we also know that Frightly and multimorbidity is significantly associated with neurocognitive disorders. Next. So in geriatrics, all of these syndromes leads us to perform comprehensive geriatric assessment with an holistic approach, and next, multidisciplinary assessments in order to stop this geriatric cascade. Next, by promoting physical activity, improving nutritional status, and focusing on polypharmacy, Frightly and its consequences can be reduced. Next, and next. Thank you. What about aging with a neurodevelopmental disorder? We have few data about aging with neurodevelopmental disorders, even if it seems to be a future challenge. For example, about 10 years ago, in autism, about 20% of patients with autism were aged over 65 years old. We know that, next please, we know that patients with neurodevelopmental disorders have a lower life expectancy, a reduced care access, and more neurocognitive disorders. But frequently, they have also an atypical clinical presentation, so this is difficult to screen and diagnose geriatric syndromes. Next. Nevertheless, we have some data in intellectual disability people. They have an higher and earlier multimorbidity, which is significantly associated with an higher mortality, with an odds ratio around 3, and polypharmacy seems to play a key role in this process. Next. Furthermore, neurocognitive disorders are more frequent in this population. For example, in Down syndromes, patients developed amyloid plaques from about 40 years old. It is due to the presence of the gene coding for the amyloid precursor protein on the 21 chromosome. And next, the clinical presentation is heterogeneous. Some patients have symptoms from 40 years old, and 1/4 of them haven't any symptoms after 60 years old. Next. ID people have also an higher and earlier frailty. Next, and this frailty is predictive of death 3 years after the diagnosis, with an higher risk than in general population. The odds ratio in general population is around 3, and in ID people, it is around 20. So it's really higher. Next, what about aging with ASD and ID? Because we know that autism is frequently associated with intellectual disability. Next, we know that in autism, patients have an atypical brain growth with a possible degeneration after adolescence. So we can suspect more neurocognitive disorders in adults. Furthermore, next, ASD patients have also a specific inflammatory pattern. Thank you. With a chronic low-grade inflammation. And so you can see me coming. Chronic inflammation, that is to say, probably inflammaging, multimorbidity, and frailty. Next, they have also a specific nutritional pattern due to their feeding disorders, in particular their food selectivity. So now you know that nutritional status is very important in multimorbidity and frailty emergence and maintenance. So we can ask, what about their aging? Next. We have few data about comorbidities and multimorbidity, furthermore in adults, and we have no data about frailty in autism. But we have next some arguments to hypothesize a pathological or accelerated aging next. And that's the reason why we have made the EFAAR studies here in Montpellier, in the south of France, in order to answer to these questions. Is there any premature aging in adults with ASD and ID? So we have included 63 adults with ASD and ID, the both. And we have assessed comorbidities, multimorbidity, polypharmacy, and frailty at baseline. We have also followed up them by collecting falls, deaths, and hospitalization each year, during 5 years. Next, participants of our cohort are severe ASD ID adults, next, with an high score at the CAS, and also a low score at the violence scale. Next, and the mean chronological age of this cohort is 45 years old. Next. We have frequently gastrointestinal disorders in CES participants with a prevalence around 60%. Mental disorders, in particular depression and hyperactivity, and neurological disorders, essentially epilepsy. These 3 comorbidities are not a surprise. This is well described in ASD children. But next, we have been surprised by another result, with 1/4 of our cohorts having kidney failure. And they are young adults, so this is very surprising. In order to understand, we have analyzed associated factors, and we have discovered that this kidney failure was significantly associated with cardiovascular risk factors. Next. Comorbidity burden is high, and it is comparable to a geriatric population aged around 80 years old. Next. It is also associated with age, autonomy, and polypharmacy. And it is also associated with a high level of CRP. So it is in line with our hypothesis of premature or accelerated inflammaging. Next. Multimorbidity is also high. In general population, the prevalence is around 20%. Next, it increases to 70 to 80% in ID people. And next, it's over 80% in our ASD-ID population. We have also performed next cluster analysis to highlight endophenotypes, which are significantly distinguishable, sorry for the pronunciation, on the basis of multimorbidity, autonomy, and polypharmacy. In young adults, 2 endophenotypes have been observed. The first with autonomous adults with low multimorbidity, low polypharmacy, and no gastrointestinal disorders. And the second one with less autonomous patients with an high multimorbidity level, high polypharmacy, and lots of psychotropic drugs, and in particular more mental and neurological disorders. Next, and in older adults, we have only 1 endophenotype with better autonomy, with a less severe ASD, but on high multimorbidity, in particular with a significantly higher prevalence of cardiovascular, kidney disorders, and epilepsy, and with an high polypharmacy, but few psychotropic drugs. So the question is, why do we have only 1 endophenotype in older adults? The question is perhaps, but it's only an hypothesis. Young adults with more severe ID and IASD and less autonomy doesn't seem to get older. So perhaps they have a lower life expectancy due to their multimorbidity, but we have to prove it. About Frightly, we have observed an high Frightly index significantly associated with age and polypharmacy. And we have calculated the biological age using the formula from general population. Our cohort has a mean chronological age around 40 years old, and next we have found a biological age around 90 years old. Next, finally, polypharmacy is also higher than in older adults from general population, and higher than in older ID people in comparison to our cohorts. So we have observed high prevalences of geriatric syndromes in our ASD-ID population with a lot of polypharmacy, even if the general population formula to determine the biological age is not really adapted to our specific population. There is a huge gap between the chronological and the biological age. So there are some arguments for a pathological or premature aging. Next, please. And next. And that's the reason why we want to promote an early comprehensive geriatric assessment for such patients. Next. So we want to develop a dedicated geriatric care network, but why? Let me speak about Emily case. Emily case next is a 35-year-old woman who suffered from a severe ASD and ID. And she came at our geriatric consultation because of an autonomy loss. And during the consultation next week, we have observed some autistic symptoms, but we have also observed some new or more intense frontal symptoms. So we performed a CGA and a cerebral PET scan, which revealed a decrease of the frontal metabolism. So in view of this possible early frontal neurodegenerative disorders, we have adapted the care for this woman. Next, and so, with occupational therapy, psychomotricity, speech therapy, but also we have searched a new institution which could be able to manage future complications of this accelerated aging, such as walk or swallowing disorders. Next. With our holistic approach in geriatrics, we can promote autonomy, reduce polypharmacy, screen cardiovascular risk factor, protect the kidney, or manage the epilepsy of our NDD patients. We have to anticipate aging trajectories and to better address personalized medicine for our NDD patients. Here in Montpellier, we have opened a dedicated geriatric consultation since about 2 years for NDD patients, and we try to focus next on polypharmacy, but not only. Next. We have also a teleconsultation since about 1 year for very severe operations. Next, and in about 3 years, we will have a multidisciplinary platform to perform CGA for these patients. Next. We have also to develop research because we have no adapted tools for screening, diagnosis, or prognosis for our NDD patients. And for example, it's very difficult to make the diagnosis of neurocognitive disorders, how to do an MRI or lumbar punctures for these patients. Next, for Fretley, we can use the Fretley index, but screening about 100 clinical and biological variables is not very pragmatic. Next, in EFAAR, we have tried to use the phenotypic model, but for example, for the muscular weakness, we used the grid test and it wasn't feasible for about half of our participants. Next. To conclude, NDD is suspected of pathological aging, and that's the reason why we think that we have to promote early CGA for these patients. But we have also to develop research in order to develop non-invasive tools for daily practice for these patients. And you will see wonderful research in this field with Angelo Carfi. Thank you for your attention.
Thank you, Stephanie. So we will now hear Angelo. The discussion will be for the two presentations, and we will hear Angelo on the use of a comprehensive geriatric tool to evaluate adults with rare disabling diseases. Thank you, Angelo.
Don't worry, Anne, it was only in case of questions you can split.
Hello.
Hello, we can hear you, no problem.
Everybody. Can you hear me correctly?
Yes.
Good. So thank you very much for involving me into this conversation. I will take my presentation as quick as I can so we can leave room for discussion or for going deeper. And
Angelo, please let me, which are your slides, because I don't see the difference.
Go ahead.
Yeah.
Down?
Down.
Celle-là, Anne, était celle de Stéphanie en backup, donc tu peux avancer.
Okay, sorry.
Voilà, c'est là.
Okay. Yeah. So my presentation has a lot of pictures. It's really easy.
So you would prefer to share it? Is that what you said? Whatever you want.
This one. Let's start from here.
Fine.
So this is a very big hospital where we practice in Rome, and it's a big university hospital, but we actually have a very, very small practice. The next one, please. It's a room filled with people. And so this is to say that this is innovative and frontier practice. So don't expect to have a lot of room for you, for those who are listening and want to start something like that. But it's really fun, and you can see here lots of people with Down syndrome. The one you see on the right side, she's more than 70 now. So this is to show that Down syndrome usually leads the way in this sort of practices because of the prevalence of this condition in the population. Next one. But the other syndromes follow. This is me together with a patient, an adult patient with the Prader-Willi syndrome that we are starting to assess these days. We also have a Fragile X, Williams syndrome, tuberous sclerosis complex, and many more that, yeah, as geriatrician, we don't usually see. So it's also challenging for us to learn these new conditions. Next one. So I wanted to state one important point, which is to me the most important characteristic of these kind of patients. And as Dr. Mio already explained thoroughly, there's chronic conditions, multimorbidity, polypharmacy in this kind of populations. And next one. And this is to show the prevalence of the diagnosis we encounter both in the younger subjects and in the older, and also the burden of therapies we manage. And next, please. So this is what I wanted to say is the key word for me in our job, and it's complexity. So all these syndromes, all these patients share a common feature, which we like to call complexity. And this changes the paradigm of on how we assess these subjects. Next one. So this is the typical paradigm of medicine. So we have a patient, we go through the anamnesis, the physical examination, the blood test, and whatever you want. You go to a medical diagnosis, and you produce a medical treatment. You propose a medical treatment. Next one. But in our patients, which have this complexity inside, intrinsic complexity, the paradigm changes. And the next one, and we have the multidimensional evaluation, which is fundamental to properly assess these patients. And you can see that complexity is shared by complex older adults, and adults with Down syndrome, and adults with other syndromes. And together with the medical diagnosis is fundamental to have the comprehensive geriatric assessment. So we need to basically measure functioning in physical and mental and social domains. Because in complexity, the thing that orientates, that helps you decide and choose wisely with these persons is the functioning. So I'm saying what every geriatrician has in its own DNA. So this is the way geriatricians think. And I took this picture from a paper talking about Down syndrome. So this is it was very striking for me to look at someone else who was doing things like Down syndrome and did think perfectly as a geriatrician. So next one. So we to face complexity, we need to have a picture of the functioning of the persons. In our institution, we use the InterRAI suite of instruments. It's a geriatric derived suite that assesses multiple domains, socio-demographic domains, clinical outcomes, and physical and cognitive status, functioning, behavior. and all that stuff, but has been cut to picture in a better way the intellectual disability persons. So there's the paper form, there's the next one, there's the electronic implementation. Next, please, which we use. And it's a kind of a burdensome evaluation, which takes, let's say, 20 to 40 minutes to be completed, and it can be completed by a nurse or a health a case manager or a doctor, and really is able to capture what usually, let's say, a geriatrician captures with his practice and with his eyes, and after knowing the patient. And it's really nice because next one is able to synthesize the many items addressed in global functioning scales. So here you can see with the time on the x-axis and the prevalence of people within the functioning domain. So you perform this scale, which is very thorough, and it brings out the level of functioning, and you can monitor this in time, for instance. Next one. And this is just to showcase that there's the depression rating scales that can help to monitor in time the mood status of the person, the cognitive performance scales for cognition. Next one. Next slide, please. Oh, previous one. Okay, and also the levels of communication and also social withdrawal, and so it's yeah, it's very deep, and it's able to show the level of the person. Next one, please. So here, yeah, this slide is not showing perfectly, but it doesn't matter. We wanted to apply our multi-dimensional evaluation in relation to the COVID-related lockdown, and we were able. We took those patients with longitudinal data, and we called them by the phone and did the evaluation after the first 2 months of lockdown. And these graphs, you can go to the paper, maybe it's easier. And the previous one, excuse me. And these graphs show you how these scales were able to show a change related to the lockdown. Next one. So this is to show that this is not something which is, let's say, for a few people. If you see the statistics here, this is from 5 years ago, and in the United States on Down syndrome. In the 1950s, you see most of patients with Down syndrome, they were for the pediatrician below the age 18, and just a few were for the adult care. But if you see 2010, we have the higher prevalence of people with Down syndrome who age more than 18 years. So they really need someone who is able to take care of them. So it's not It's not something that is not needed at the moment. And the families and the persons really feel they are left alone when they at their 19th birthday. Next one. So the take-home messages is the adults with ID have an outstanding intrinsic complexity. The geriatrician has the background to deal with it. And there's plenty of multidimensional evaluation tools, including the one we use, that can picture the complex need of this population and can help monitor how this goes in time. And Internet suite of instruments can cover this. Next one. And this one is to point out that, yeah, it's a frontier job, but it's really, really rewarding and fun. Thank you.
The discussion will be now animated by Matthias. So Matthias, I think you...
Yeah. Hello, do you understand me?
Yes.
Perfect. Sunny hello from Zurich in Switzerland. First of all, I got from both your presentations because I just feel and think the work you guys are doing is just amazing, fascinating, and thank you very much for this work. Stephanie, I would like to start with you because you were first and you're the lady, of course. Amazing study. A lot of patients, 5 years of follow-up. This was a lot of work. And what I find very striking are two things. The comorbidity burden, that given the mean age of your patients, it basically, as you said, compared to a 80-year-old person. One thing, and then also Angelo mentioned, talked polypharmacy. So I'm wondering, what ways of reducing polypharmacy have you guys figured out?
I mean that we have to manage first psychotropic drugs because this is a very specific population in EFAAR study because they have ID but also autism. And psychotropic drugs are used only for a sedative objective, and this is not an etiological treatment. So, and it induces a lot of side effects, such as gastrointestinal disorders. And we know that they already have gastrointestinal disorders, so it increases their gastrointestinal disorders, for example. They have also a specific walk pattern, and psychotropic drugs don't help them. So I mean that the first things to work is the psychotropic drugs, because when the disease when the patients are getting older, we can observe not so much behavior disorders, so that it can be tried. But sometimes for these patients who are living in institutions, they are frightened, they're afraid of reducing these psychotropic drugs. So we have also to find some a new organization in our care, because sometimes it could be easier to reduce polypharmacy during an hospitalization, but these patients haven't any place in hospital because we haven't made a place for them. Psychiatry said they have too much somatic comorbidities, so it's too complicated for us. In somatic care, they say there are too much risk of behavior disorders, so nobody wants to care this patient. And this is we have to reorganize our hospital in order to give them the possibility to reduce this polypharmacy.
Well, I guess one of the wonderful things of your work is that you point out that polypharmacy is a big issue, right? And once, as long as we do not see that polypharmacy is an issue, we cannot solve it.
Yeah.
I have 2 questions left, Stephanie. Number one, from a practical approach, how long does a comprehensive geriatric assessment in your patient usually take in minutes?
For the consultation, for the first consultation, I take about 90 minutes. And for the follow-up, I take about 1 hour. But this is only the consultation. And for the CGA, we do it in the day hospital, and we take 1 day. But for the moment, this is not optimal. So that's the reason why we will have a dedicated platform in 3 years, in order to have also an environment adapted for these patients, because they have a very specific sensitive profile, so that you need less light, not too much sound. You also sometimes need a very quiet place with lower sensorial stimulation, because they feel very anxious. So it will be better in 5 years, in 3 years, I hope.
Okay. And the last question, and this is a little tricky one, given the time, maybe try to give a short answer. Based on your work you have right now, what is the one thing you say this would have been nice to know 5 years ago?
I haven't heard the end of your question.
When you think about your work right now, what do you think is the one thing it would have been nice that you already would have known 5 years ago?
You mean what we need to improve, or what have been improved?
Yeah. What do you think would have been good to know already?
What will?
Now we have lens work. Well, given the time, let's go to Angela.
Maybe Matthias, you should use the chat if you can.
Yeah, yes, use the
you
chat.
have a problem.
I don't heard you. I'm very sorry, Matthias.
Yeah, Angelo, Angelo, yes. Please, Angelo, unmute.
Here I am.
Perfect. Thank you very much, Angelo, for your presentation and your wonderful approach with those patients. Seeing you smile and seeing those patients smile, I think that's a real joy. I was also struck with the polypharmacy and multimorbidity burden of your patients. And you've showed this slide that about 16–20% of your patients have GI problems or medical drugs for the GI system. I'm wondering, are there any non-pharmacological approaches who work well in patients with Down syndrome, maybe to reduce polypharmacy?
Yeah, the topic of polypharmacy, is a little bit tricky, because it depends on how you measure it, the cutoffs, and so the prevalence can be very variable. and and sometimes at least this is my opinion on that. A lot of polypharmacy is because there is a stratification of prescriptions in time made by family physicians or consultants. This is why it is very, very important that at the very end there's someone who tries to prioritize things, which it should be the trained physician for the, in this case, the adults with ID. Because, for instance, we have a group home in my practice. People from a group home, everybody that takes drugs for their veins, so which are absolutely useless, but they're very affectionated to them, and I cannot touch it. So so the strategy to me is to review the drugs and to check for the interactions in every visit, and to properly address also the symptoms. And many of these people, that you know, they just have a lot of drugs because they go to a lot of specialists. And when you go to a specialist, the specialist feels some way asked to give you something special. Okay. This is the very point, is to be accessible by these people and to prioritize things. And this could be a rule of thumb.
Angelo, given the time, one last question, please provide a quick answer. Your inter-IDs assessment, how long does it take?
Okay, to me, after I know a patient, could take between 15 and 20 minutes. If you see the patient for the first time, it could take 45 minutes.
Okay. Well, given the time, again, Stephanie, Angelo, grazie mille. Thank you very much for your great work. Keep on going.
Thank you. Thank you all.
There's also one question in the chat from Laurent Pasquier in Rennes, in France. How do you deal with the family practitioners in general, and in particular to enhance public health policies about cancer screening, usually offered after 50?
In Montpellier, we don't have any program cancer screening for this population, but we try to favor an early screening. And for the other aspect of the health, we try to implicate the general practitioners in the care. We usually work together in order to synthesize all the exam and also the consultation to other specialists, because as Angelo Carfi said, these patients have a lot of doctors, and it is sometimes difficult to do the summary.
Just one quick comment on this. I suggest it's really important to know the syndrome you have in front of you, because for instance, cancer screening could be absolutely useless or absolutely mandatory, so you should learn in each case.
Okay, thank you, everybody. Just before giving the transition to Titschke to go on work package 9, Alain would like to address us a few words. So, Alain, it's your turn.
Thank you so much. So I'm really impressed by the number of people following this, and because it's the first webinar we talk about intellectual disability and aging, I wished just to say a few words. First, to explain why ITHACA is probably for many people something that deals with young children with multiple malformation and intellectual disability, but these topics on geriatrics may be a bit out of the world of ITHACA. In fact, it's not out of the world at all, and that's one of the reasons why we have built within the ID group some ideas, and one of these ideas is to question how do we have to deal with those patients who have aging problems, aging and intellectual disability, because I think in most European countries this is not something that is covered correctly and with no correct strategies. And so within ITHACA, the idea was first to think about should we or could we have good practice recommendations to tackle those patients for which screening for common disorders, for instance, is far from being well described and well organized. And so one of the ideas within ITHACA is to try to have some recommendation of good practice about that. But also because if you are a pediatrician and you are used to give poor diagnosis to parents of children, you know that one of the questions is how will my child be in 20 years? How will it evolve? And one of the main difficulties we have with all of new genes and new disorders is that in fact we have no IDs. We have a general ID for most of the disorders, even those that we think we know well. We have no idea of how they will be in the age of 50, which are the specific complications of this or that disorder, and which should be the recommendations targeting the diagnosis, the cause of diagnosis. And so that's the second reason why I think this endeavor is important, and the joint between geneticists and geriatrists is probably important, is to try to have a better natural history of those rare disorders. And this could be built on a European basis because all these disorders are individually rare, and maybe we could have some cohorts of some of those rare disorders. And also one of the questions is to what extent do we still make diagnosis of etiological diagnosis of patients with intellectual disability when they are 50 or 60, or maybe we should do that more often because we could link some complications, some comorbidities to the etiology, not only to the aging, but to the general system. So this is many reasons for which we have connected genetics and geriatrics, and I'm really happy for that. And I think Titske will explain you what are the ideas behind this very short presentation. So thank you for assisting this so late in the week, and thank you for those who are connected from far. Thank you. Titske, I give you.
Yes, thank you very much, Alain. I think you nicely introduced why we launched this working group and focused on the adults and aging aspects of people with intellectual disability. So yeah, I'm very happy to welcome you all to listen to the second part of this webinar that will be presented by or given by Laura de Graaf. She is an endocrinologist, but specialized in developmental and congenital care aspects for care for adults in Erasmus UMC in Rotterdam, and very happy that she is on board and will be active in guiding this that we call a sub-network on the care management of intellectual disability of the adults. And she will do jointly with Stephanie, who already presented nicely in this previous hour. So Laura, I'm happy to introduce you, to give the floor to you. Not sure if it's going automatically. Yeah.
Yeah, I think it is. Thank you, Titske, for the introduction. And yeah, I'm very happy to be part of this webinar. Actually, I was not involved in ITHACA until very recently. So I'm really enthusiastic about this new collaboration. I will tell you something, next slide, please, about multidisciplinary care for adults with intellectual disability as part of a rare genetic syndrome. And as Jitske said, I'm an internist endocrinologist, and I would say I'm like in between the clinical geneticist and the geriatricians, because I don't only see adults of older age, but also younger adults. So I think that's a good continuation of the spectrum. Next slide, please. These are my disclosures. Next. Well, for those who don't know, this is the Netherlands. Next slide. There is Rotterdam with the Erasmus MC. Next. And this is my hospital. I think the part on the left you already know, because that's Encore. That's a large center of reference that sees a lot of children with rare genetic syndromes. And they asked me to take care of the adult follow-up. So on the right in the blue arrow, that's where I work, and I launched this outpatient clinic for adults with rare genetic syndromes. Next slide, please. So our Center for Adults with Rare Genetic Syndromes is part of Endo ERN, because we have a lot of endocrine syndromes. And as I said, just recently being involved in ITHACA. Next slide, please. This was the problem of the pediatricians, and also of their patients. So after years of multidisciplinary pediatric care, there was like a dead-end street. There was, like Angelo said, after the age of 18, there was nowhere to go. And that was really a large problem. That's why they asked me to take care of the adult follow-up. Next slide, please. So, and in the Netherlands, there's a separate specialism for pediatricians that's called genetic and developmental pediatricians, and has been here for 25 years. But there was not an adult version of that specialism yet. So the pediatricians have like a pool of adults with rare genetic syndromes between 18 and 24 years now. And they just can't transfer them to adult care because there was no multidisciplinary care for them, and there were no experts. And as Angelo also said, if you don't know the syndrome, you really can't treat it well. You really have to be aware of the pitfalls and of the special needs of patients with the different syndromes to be able to take care of them well. So that's why why this new specialism was important. So in 2015, when I ended my medical training, I launched this new center. Next slide, please. So what we do, of course, we provide multidisciplinary patient care. That's what I will tell more about in a few minutes. And because we are the only one with regard to internal medicine within the Netherlands, all the patients, from all over the country, they come to Rotterdam. And I would love to see it differently. I would love to have more centers in the Netherlands who take care of this in the field of internal medicine. But it also gives us the opportunity to collect larger cohorts of patients with rare disorders and to see what their natural history is like. So the question that Alain said, how will be my child in 20 years later? That's something that we try to register. So what are the problems at adult age? And I think the cohorts that we are now collecting help us to describe the adult manifestations of each of the syndromes. So apart from patient care, we do a lot of research, and new knowledge that we obtain, we try to share it as much as possible through books or, webinars, publications. We have a lot of international collaborations. For example, we have launched a large international network of endocrinologists who take care of adults with Prader-Willi syndrome. And also in the rest of the Netherlands, you would say it's a small country, and it is, but we have a lot of inhabitants. So I think it's important that there are more centers like our center, and that's why we try to help other hospitals to start similar outpatient clinics. Apart from that, I have launched a network of internist endocrinologists from all over the Netherlands who are, let's say, specialized in rare genetic syndromes. And I'm very happy to have more colleagues doing the same thing as I do. But the problem is that, as far as I know, in internal medicine, there is no other person doing this. So this is my question. If you know of internists, endocrinologists somewhere in the world who are doing the same thing, please let me know, because I want to collaborate and I want to exchange ideas and exchange knowledge. But in the last 5 years, I have not met anybody doing the same thing, unfortunately. Next slide, please. So the purpose of the Center for Adults with Rare Genetic Syndromes is improve patient care by this multidisciplinary approach. And then, as I said, do scientific research to obtain more knowledge about the adult manifestations. And it's also by registration, the medical problems that they have at adult age. And I think, and I'm convinced that we can prevent a lot of misdiagnosis, because our general health screening already reveals so many misdiagnoses that I'm convinced that we are able to improve patient care by doing this. And I think by detecting diseases in an early stage, we can prevent complications at a later moment. And we might even reduce mortality in this vulnerable patient group. So that's really what my aim would be. We try to prevent overtreatment. And one of the examples is for hydrocortisone treatment in adults with Prader-Willi syndrome, PWS. You might know that in children with PWS, adrenal insufficiency is quite common. So that's a lack of stress hormone, and that can cause them to become really, really ill in case of an infection. So the pediatric guideline says, in case of disease, in case of illness, give extra stress hormone, hydrocortisone, to all patients. But we found that in adults, this adrenal insufficiency is extremely rare. Only 1% of the patients of adult age has this hormone deficiency. But still, they were all treated with stress hormones in case of disease or fever or psychological stress. So that was a huge overtreatment. And thanks to our international research and in collaboration with these other endocrinologists, we are now able to de-implement this strategy that's really not helpful for the older patients with PWS, especially because hydrocortisone, so stress hormone, has a lot of side effects if you take it regularly, like diabetes, weight gain, osteoporosis, and those are problems that are already really common in adults with PWS. So we really have to prevent this overtreatment, and I think that's what we are able to do now. Well, another thing that we try to prevent is undertreatment. And that's also, well, I see a lot of patients with PWS, so that's one of the examples that I've seen in my clinic, that sometimes those patients are living in a residential home, and they are sometimes really passive and not able to take care in activities like going outside or other activities. And sometimes this situation of inactivity is just accepted because the caregivers or physicians, they think that this inactivity is just part of the syndrome, and they don't look for underlying pathology. But we notice in our clinic that the healthy people with that syndrome, they are not passive and they are not inactive. They can easily do day trips and other activities. So when they are so tired and so inactive, you should really look for an underlying cause. And I think by learning that and by sharing that information with other doctors, we can really prevent undertreatment of this population. So I think, well, what we can do by gathering these larger cohorts of patients with rare disorders is improve medical care, write adult guidelines, because for a lot of the genetic syndromes, there are no guidelines for adults. There are just guidelines for children. And if you keep on following the guidelines for children, then you are either overtreating or undertreating the patient, because adults are not just bigger children, they are really different with sometimes other pathology. So it's very important that adult guidelines are made. And I think if we manage to improve healthcare like this, it will also reduce healthcare costs in the end. And most importantly, improve quality of life of those patients. Next slide, please. So this is how patients reach our center. So they are either referred by the pediatric endocrinologist or by the genetic and developmental pediatricians, and also a lot of idea physicians, so physicians for intellectual disabilities, also refer the patients to our center. Next slide, please. So this is our workflow. So when a patient is referred, we use medical questionnaires to prepare the medical team, the multidisciplinary team, for the visit. So there's a lot of general questions in this questionnaire, and we ask for a lot of physical complaints and for the medication they take. And then we can choose which members of the multidisciplinary team have to be present at the day that the patient visits us. So I think that's a useful way to provide good care. Next slide, please. Well, this is what the multidisciplinary outpatient clinic looks like. We have 2 internists, 1 dietitian for intellectual disabilities, a neuropsychologist, and 3 ID physicians, and a nurse practitioner in the middle who coordinates all the care. Next slide, please. Well, this is just what one example of a questionnaire looks like. So first we ask for the medical history. We ask for the medication that they take, the family history. For example, if a certain kind of cancer is really common in that family, then we know we have to screen for that, regardless of the syndrome that they have. This is also important to know. And then we ask for all kinds of physical complaints, and then those are rated on a 5-point Likert scale. And we also ask for social aspects like work, school, daycare. Where do they live? Do they live with the parents or in a residential home? And because we use these questionnaires, we have more time for good conversation and to put the patient at ease, because most of them are really excited to come to the hospital. They are sometimes really nervous. So you need the time to make them more relaxed and to be able to do a physical examination. So by using these medical questionnaires, we save a lot of time for asking standard questions, and we can use that time to pay more attention to the human part of the visit to the hospital. Next slide, please. So after taking the medical history and after doing the physical examination, we do biochemical analysis, so blood tests in all of the patients. And that is because there is not much known about the internal medicine problems in these adults. For most adults with rare genetic syndromes, there are no publications, there is no information about, for example, hormone deficiencies or kidney problems or liver problems. So we have to start from zero, and most of them present with fatigue. That's the most commonly heard complaint. And then we have to take blood anyway. So if they go to the lab to give blood, then we just check all the other things, also to reduce this number of missed diagnoses that I was talking about earlier. Next slide, please. I think it's important to emphasize the importance of multidisciplinary care, because I could not do this on my own. Internal medicine is just one part of the syndrome that they have, and they have a lot of other problems. So apart from the things that I do, like replacing hormone deficiencies, treating diabetes, treating liver and kidney problems, we have this dietitian for intellectual disabilities, who is, I think is very important, because some of the syndromes, they are associated with hypotonia and low muscle mass. And if you have such a low muscle mass, you don't burn so many calories. So a normal diet would be a too high number of calories, and they would gain weight even if they stick to their diet. So this dietitian is aware of all the basal metabolic rate differences between the syndromes, and she tries to adjust all the diets according to the genetic syndrome that the patient has. Then we have a physiotherapist, also to increase muscle strength and muscle mass. And we have this idea physicians, that is a specialized or a medical specialism in the Netherlands, and they are specialized in everything that has to do with living with intellectual disabilities, so the legal part, daycare, group homes, all kind of behavioral issues, and that's really what their expertise is. Then we have the neuropsychologist, and that's also, well, I would say one of the most important parts, because especially in syndromes like Prader-Willi syndrome, where patients have a high verbal IQ but a very low performal IQ, these patients can easily be overestimated. They sometimes use very difficult words. So if you hear them talk, you think they are quite intelligent. And then if you test their performal IQ, you notice that they are really not that intelligent. And because they appear more intelligent than they really are, they are easily overburdened by their caregivers and by society. So this neuropsychologist, of course, can test what they really can and what they really need. And I think that's a good way to prevent overestimation and overburdening. Well, the nurse practitioner, as I said, she takes care of the coordination and also the psychosocial aspects. And the clinical geneticist, of course, very important, because we have a lot of patients who are referred for a certain kind of syndrome. And then when I see the patient, I think, I don't think you have that syndrome. That's a wrong diagnosis. And then they go to our clinical geneticist. And many times they confirm that the syndrome is actually a clinical diagnosis, but it was not genetically proven. Especially in Prader-Willi syndrome, there are a lot of people with the diagnosis of Prader-Willi syndrome who actually have the wrong diagnosis, I'm afraid. And it's also confirmed by the clinical geneticist. Next slide, please. So this is one slide just one example of a complaint and how we approach that complaint multidisciplinarily. So if somebody comes to our outpatient clinic with complaint of fatigue, I check for all the internal medicine causes of fatigue, like hormone deficiencies or cardiopulmonary disease or kidney failure, etc. Then the ID physician also adjusts the psychotropic medicine, because they can cause fatigue also. So in case it's possible to reduce the dose, then we always try to do that. Then the neuropsychologist, as I said, tries to reduce the overestimation and the overburdening of the patient to improve the way that caregivers handle that patient. And sometimes this can really reduce stress and also reduce fatigue. Then the dietitian looks at the nutritional status, and the physiotherapist tries to improve exercise tolerance. So that's the way we work in the team. Next slide, please. This is an overview of it's not complete, but just a short overview of some of the symptoms that we have seen. Since we started the outpatient clinic in 2015, we've seen over 750 new patients with over 60 syndromes. And some of the syndromes are larger groups, like Prader-Willi syndrome. We have 140 patients now. Turner syndrome about 200. And of course, those are the syndromes that we know most of. That's the way we learn. Next slide, please. I'm just looking at the time. I have one clinical example of how you can see how we work. Next slide, please. This is, let's call him John. It's not his real name, but for privacy reasons, I could show his picture actually. He allowed me to do so. This is a typical case of undertreatment. John has Prader-Willi syndrome, 25-year-old. He was tired, had a poor exercise tolerance, and he was so tired that his mother took him to the general practitioner. And the general practitioner checked Google for Prader-Willi syndrome because, of course, he was not familiar with it. Most GPs are not familiar with those rare syndromes. And this GP found at Google that Prader-Willi syndrome could be associated with hypothyroidism. So he checked his thyroid stimulating hormone, which was normal. So he told the patient and his mother, you don't have hypothyroidism. And after that, well, the caregivers just accepted this fatigue and this tiredness because they thought, well, if all causes are excluded, then it must just be part of the syndrome. But at that time, his mother decided to come to our outpatient clinic for like a second opinion. That's too early. One slide back, please. 2 slides back, please. Yes, thank you. And of course, when you know that PWS is associated with hypothyroidism, as an endocrinologist, you know that this is central hypothyroidism. So it's hypothyroidism of hypothalamic origin. It's caused by hypothalamic dysfunction. And when hypothyroidism is of central origin, then you can check a TSH, but it will always be normal. So the GP checked it, but it was not useful because the TSH is not a problem in that kind of hypothyroidism. So we checked for central hypothyroidism and we saw that he had a huge hypothyroidism, a very deep thyroid hormone levels. Apart from that, the general health watch that we did, the medical screening also revealed hypogonadism. He had an unmeasurable testosterone levels, which of course can also cause fatigue. And he had an unmeasurable vitamin D. So we replaced all these hormones that he was missing. Our dietitian put him on a PWS adjusted diet. The physiotherapist started practicing to increase his muscle mass. And then after 12 months, and I can show the next slide, please. He was like 25 kilograms lighter and so much more active. And he was so proud of his new me, as he called it. You can see in the photo that it was really an improvement. So this is what I wanted to show you, that by treating the patient in this multidisciplinary setting, we are really able to improve their quality of life, and that's so rewarding, really. Next slide, please. So to conclude, I think it's very important to have multidisciplinary care for adults with intellectual disabilities, also as part of rare genetic syndromes. I think we can prevent a lot of misdiagnosis and complications. And by reducing overtreatment and undertreatment, I think it's really feasible to improve medical care and also to reduce healthcare costs. And most importantly, improve their quality of life, because that's what it's all about. Next slide, please. So this is all the staff and all the collaborators of our Center for Adults with Rare Genetic Syndromes. I'm very happy that in 5 years' time we have reached such an enthusiastic group, and yeah, we can help so many people. So this was what I wanted to show you, and thank you for your attention. Are there any questions? I can't hear you.
I'm muted, yeah.
Yeah.
Thank you, Laura, for your model. It's very interesting. I am Pino Zampino from Rome. I am a pediatrician and a clinical genetician. Well, it's real that the transition is the big problem of children with disabilities, because the transition is a natural process in which there is a physical maturation and a psychological, intellectual autonomy. So it's valid for all the different kind of specialty, oncology, cardiology, hematology, but is not valid for children with disability, because they never became autonomous in the psychological, and sometimes never became with a mature structure. And we have, your examples are very interesting, but there are other examples, for example, the children that, or the adults that remain always children, for example, remain small, always dependent from the parents, and never have a puberal evolution. So I think that these are a very tricky group, because it's very difficult to do a real transition. Because if an internist has in charge of these children, they use, for example, drugs that are the drugs for adults, but they are so small that you must use the drug as a pediatrician is able to do. So, which is your experience in this kind of children?
That's a very good question. Thank you. Yeah, I share your opinion, and we have some patients, for example, with DNA repair disorders, or some rare congenital hypothalamic syndromes, and they are indeed very small and sometimes only 30 kilograms. So then we adjust the dose to their body weight. And if, in case we doubt about it, we always talk with the clinical pharmacologist or with the pediatricians, because we have a close collaboration with the pediatricians. But I think the fact that they are small is not the only thing that we have to keep in mind, because their bodies can be small, but if that body is 40 or 50 years old, the kidney function and the liver function will be of an adult or maybe of an older person. So I think when these patients stay with the pediatricians, it's also not good. So I think that's why I think that syndrome internist should be a new specialism, because you have to keep in mind both things like body weight and body size, but also the maturation of the organs, because that's independent of body size. And one other example is, there was a patient with a yet unknown syndrome. He was 40 years, but totally pre-pubertal. So he had a very small body. And there you have to keep in mind that because of his hormone deficiencies, he was still small and he really looked like a child, but he also needs those hormones to prevent, for example, osteoporosis. Because if he stays hypogonadal all his life, he will get osteoporotic fractures. So sometimes we induce puberty by giving them the hormones that they are missing, to make sure that they don't get those problems at older age. But I agree with you that there's like there's like a link between pediatrics and internal medicine. You cannot see them as a total child, but also you can see them as a total adult. So you have to be a bit of both.
Thank you. The second question is all the these conditions are chronic conditions. So there is a necessary to understand how the adult lives. So how do you manage the relation between the hospital and the territory?
You mean between the hospital and the healthcare institution where they live, right?
Yes, yes.
Yeah. Well,
if live in institution, but they can also live in the family, for example.
Yeah. Well, that's the reason why my job takes too much time, because the communication with the institution where they live or the communication with parents is so much more complex than for regular patients. I also have a regular endocrinology clinic without syndromes. And there you have a treatment that you want to start. You give the patient the medication and you see him back in 4 months. And then that's all you have to do. But here you have to communicate with the residential home where they live, also with the parents, because that's where they stay in the weekends. And you also have to communicate with the intellectual disability physician who manages the healthcare institution, and sometimes even with the general practitioner. So to start one treatment and to make sure that that treatment works well and is given to the patient, and to make sure that they take the drugs or they are given the drugs that they need, you have to communicate a lot. And you have to inform all the people involved, so from caregiver to ID physician. So that's, I think, what's the most complex about this patient population, because if one of those factors is not doing what it should do and is not giving the patient the medication, then your treatment fails.
Thank you.
Welcome.
There are some questions.
Well, yeah.
Other questions?
I have one. How do you manage connections within the hospital with the other adult services? I think one of the difficulties we have in many places is that adult services don't like to have patients with intellectual disability because they are not used to them, and they are not caring them and not supervising them correctly. And when you have a child, an adult with appendicitis or any acute disorder that has to be hospitalized, for instance, in Paris, despite the fact that they have 12 million inhabitants, there's not a single ward that is dedicated to patients with intellectual disability. You can put them in neurology. This is, I think, the only one that have structures that can keep them avoiding the escape, for instance. But it's real difficult to. Did you succeed to make something in the Netherlands?
Yeah, good question. That was really hard because, as you say, the other specialisms, they really don't like this kind of patient. And it made me so angry in the beginning because they were really reluctant and they did not want to see them. But now, in the past 5 years, I have found a small network of cardiologists, oncologists, nephrologists. So in each of the specialisms, I have 1 or 2 nice human beings, doctors with human skills or with affinity for this group of people. So now I think for all specialisms, I have somebody who does care about this specific patient group. And I agree that that's difficult, but yeah, in the end I managed. But it took me quite some years to get this collection of human specialists.
Did you succeed in finding hospitals or just wards that accept those patients easily?
Yeah. When they need to be when they need to stay in hospital, then they can come to my ward. That's internal medicine and endocrinology. And our nurse practitioner goes by every day, and she also puts a lot of time in educating the nurses on the ward. So how do you deal with somebody with an intellectual disability? What should you do with somebody with Prader-Willi syndrome? Why can't he have the room in front of the kitchen? That's what happened in the beginning. They put the patient with Prader-Willi syndrome next to the kitchen. And we had to really inform them that it was not practical because the food just disappeared. So it takes a lot of time, but in the end, there are some people, of course, it's never enough, but there are some people who know about this population.
Alan, can I integrate your question? In Rome, we have used a strategy that there are a pediatrician that are able to take in care a disability, children with a disability. But the internists that are able to take the care of a disability as the geriatrician. For this reason, there is a strict contact between me and Angelo and me, because the patient, when has need of an internist approach and the need of the recovery, there is the geriatrician. That is the people that are structured to taking care the chronic and disabled people. Well, so means that the geriatrician is not the doctor that is for the old people, but is the doctor that in Italy has the experience to take in care the disability and especially the chronicity. This means that has a lot of experience in the relationship between territory and the hospital, for example. So this is our model.
Yeah, then that's really interesting. And I think it also has to do with the way geriatricians are trained, because in the Netherlands, there's quite a difference between the medical training of a geriatrician and the medical training of an internist. And the internist part of the training of geriatricians is quite small. And they have a lot of neurology and a lot of psychiatry, but the part of internal medicine is quite small. So I think that's why the geriatricians in the Netherlands, they never see adults with rare genetic syndromes. That's just that's not part of their business, let's say. But I think maybe in Italy, the medical training of geriatricians has more internal medicine. I don't know.
Yes, but I think that is our model, is our experience, is not the experience of in Italy. In Italy, the most of adults remain in pediatric department, and the adults came in the in pediatric department to taking care also people of 30, 40, or 15 years.
I think we are almost finished in time, and I see also there's quite some comments in the chat and also some questions. I think we have no time to go through all, but there's also this question from Stephanie, if you have a specific program for parents and helpers, because they might, these adult patients, the parents might be, well, relatively old and afraid for the future. And do you handle that also in your practice, that you have?
You mean to take their cares away about the future?
Yeah, well, to support them and to see what's needed for them. Is there a support or some thoughts on helping the parents?
Yeah, that's a good question. Yeah, and I always ask for that when they visit our clinic. But the social support for the parents in the Netherlands is from a different organization. So that's a separate organization that focuses on the psychosocial support of the caregivers. And our ID physician always connects the parents and the caregivers with this external organization.
Yeah, and that might be different in other countries.
Yeah,
how it's organized. Yeah, and as you already commented, but there's a question: do other centers in Europe exist who work like yours?
No,
we're afraid
not for internal medicine. Of course, there are wonderful outpatient clinic from the part of clinical geneticists. There are outpatient clinic from the part of neurology with neurological syndromes. But for internal medicine, I don't know anybody.
No, we have. You mentioned the group and the ID physicians. There we have quite some in the Netherlands, and they also have quite some overlap with the work you presented. I think there is much to gain to get them more involved in the medical aspects that you mentioned. think there's an opportunity probably, but
yeah, and the collaboration with the idea physician is, as you said, very important. There's one thing that their medical training is at the level of a GP. So the medical training is only 2 years so with regard to specific hormone problems or organ problems, liver problems, they just don't have the knowledge, and they have other expertise.
Yeah, exactly. Yeah. So I see N is in the screen. Do we have to stop N?
For me, it's fine. If you want to continue a bit, I would understand. It's very, very interesting, the three topics we had today. So it doesn't matter to me, not too far, but it depends on you.
Yeah, well, actually, I do have to leave.
Yeah, we were already running over time, and I see also people leaving. So I think we should end here, and maybe in the near future we have another opportunity to have a bit more discussion within the working group. I think there's a lot of input and inspiring ideas today, so that we take forward in our working group, and exciting to work on that together.
Yeah, I agree. Well, thank you very much.
Thank you, Laura. Thank you. So I hand over to you and
Giuseppe, do you give us the word of the hand?
Thank you for this very interesting webinar. Aging in malformative syndromes with intellectual disability is an emerging and important issue. It's important for all the different points of view. So the challenges are numerous, and our commitment will be great. So thank you for your attention, and have a good evening.
Thank you, everybody.
Thank you.
Thank you to all.
Thank you for the organization also, and